I think you can start now.
Okay, fine. Thank you.
Well, I think people might feel like they just need a short break. Are you starting at 3:30, like someone has suggested?
There's no problem. We can start at 3:30 if you guys would like. That's fine.
Okay, yeah, I'll inform them on the group.
Okay.
Yes.
Okay, awesome. All right, good afternoon, guys. Sorry for the long Thursday. I think we just concluded a really excellent lecture with Prof. Kibanga. So my lecture, actually my work has been cut in half. If we haven't met, I'm Dr. Magutu. I'll be taking you through benign disorders of white cells this afternoon. Okay, so just a bit to orient you for this lecture, we're going to classify the benign white cell disorders, and then we're going to go into the quantitative leukocyte disorders and then the qualitative leukocyte disorders, and just give a few examples. So as Prof mentioned, sorry, I heard something. Did someone want to say something?
No.
Okay, that was quick. As Prof mentioned, white cell disorders, especially the benign ones, can be classified as either quantitative, where there's abnormality in terms of their numbers, or qualitative, where there's generally considered a functional or morphological abnormality. And as she also mentioned, both of these can occur at the same time. So, as I've mentioned, quantitative means that there's a change in number, and there can be physiologic or pathologic variations in white cell counts. So the cause doesn't necessarily have to be a disease. The terminology we use when we're talking about quantitative disorders or quantitative changes are when there is an increase in number, we refer to that as a cytosis, cyte in terms of cell, or a philia, and philia is like to love. Yeah? So for example, you can talk about a leukocytosis when you're talking about an increase in number in white cells, or you can talk about a neutrophilia when you're talking about an increase in number in neutrophils. Now, for a decrease in number, we generally refer to that as a cytopenia. So if, for example, there's a decrease in the number of lymphocytes, we'll talk about a lymphopenia. Or if it's white cells in general, you can refer to it as a leukopenia. For qualitative, there's not so much in terms of generalization, but I will reiterate that you can have morphological changes or functional changes. So changes in your white cell concentration and morphology will often reflect the disease process that's ongoing or the toxic challenge. Yeah? And the type of cell that's affected will really depend on its primary function. For example, in bacterial infections, neutrophils are the most commonly affected. And I think you've just discussed the function of neutrophils, and Prof might have mentioned, their function, for example, in bacterial infections, phagocytosis, etc. In viral infections, lymphocytes are most commonly affected. And you're going to go through this in depth with the immunology unit, and Dr. Barasa and Conti, etc. I'm talking about, the lymphocyte and natural killer cell function in viral infections, and so you'll see why they're the ones most affected. In parasitic infections, eosinophils are the most commonly affected. So basically, just to show that the type of cell affected will really depend on its primary function. Yeah, so it will be the one to respond to either the disease or toxic insult. So let's go into quantitative changes. Now, Prof has already gone through relative versus absolute values. And she's mentioned that, even when you get your hemogram, what you'll have is your total white blood cell count. And under that, they'll give you a differential count. The differential count tells you what the white cell count is made up of. It basically gives the percentages and or numbers of the constituents. For example, they'll tell you the neutrophil number, the lymphocytes, the eosinophils, basophils, monocytes. Okay, so that's your differential. So sometimes in the ward, someone will ask you what was the differential. It means that they don't just want to know the total white cell count. They want to know what contributed to that total, what the constituent counts were. How much were the neutrophils, what were the lymphocytes like, etc. And in that count, you can have an absolute count or a relative percentage. Okay, so the absolute count, she gave already an example of it being the actual number per, that volume unit, either it's liters or microliters of the cells. Yeah. So to calculate it, you usually take the total white blood cell count times the percentage or relative percentage of each white cell. So she gave an example, I think, of 5, or we can use 10. And if 30% of those cells are lymphocytes, it's 10 times 30 over 100 to give you the absolute count of lymphocytes. So we usually will give both, but for heme, we prefer having the absolute values because the relative just tells us how much of the total this cell type makes up. But what we're really interested in is the actual number. Is it really reduced? Is it really increased? So if you're, please try and focus more on the absolute, not the relative, even though for almost all hemogram printouts and reports, you're going to get both the absolute and the relative. The relative can be misleading. The absolute tells you exactly how many cells are in the volume that's being reported. Okay, so still not quantitative, we can move into leukocytosis. So this is the raised total white blood cell count due to an elevation of any of the single lineages. Though you can have all of them elevated, like you can have an increase in neutrophils, lymphocytes, all of the cell counts can be increased, or it could be just one. You can have a total white blood cell count increase, and the increase is caused by the elevation, the increase in neutrophil count. Okay, so all of those cell types could be increased, or it could just be one that's contributing to this leukocytosis. Okay. For cells that are minor cell populations, you can have a rise without causing a rise in the total white cell count. For example, basophils are usually pretty few in peripheral blood, so you could still have a basophilia, but a normal total white cell count. Okay. So I've put the reference range there of 3.5 to 11. I think Prof was using 4 to 10. And just like your HB, your red cell count, you need to remember, and this is something that they'll harp on in chemistry, that reference ranges are very population dependent, even in terms of gender, location, and race. Yeah, and we'll go into that a bit more. So what are the causes of a leukocytosis? It could be physiological, and I think Prof has mentioned a neutrophilia after quite a bit of exercise, or it could be pathological. And for the pathological, it could be reactive or benign, or the increase could be due to neoplastic cells. And we're going to cover that when you do your heme-onc lectures, next year. So for this year, we'll focus mainly on the benign or reactive causes of leukocytosis. And as I've mentioned before, leukocytosis can affect any class of the white cells, either singly, just one line, or in combination, meaning that they're all increased. So let's go into the individual cell lines. So leukocytosis affecting neutrophils is referred to as a neutrophilia, and it's defined as an increase in the number of neutrophils and or its precursors. So in adults, when you get a count of more than 7.5 times 10 to the power 9 per liter, that would be considered neutrophilia. But I will mention that counts are age dependent, and we do give, for example, when you're retaining peds, you'll probably notice a different reference range. So these increases could be due to change in your normal steady state because of increased production, or impaired transit to tissues, or because of migration or destruction. Okay, that could affect your neutrophil count. So some of the common causes of neutrophilia are infection, and specifically bacterial infection, inflammation, specifically acute inflammation, or in situations like autoimmune disorders or flare-up of gout. You can get neutrophilia in metabolic conditions like uremia or acidosis, or post-hemorrhage, the use of corticosteroids, if your marrow has been infiltrated or it's early fibrosis, and the marrow becomes a bit hostile to the neutrophil in terms of the environment is not as welcoming, you'll find more neutrophils are in circulation, so you can get a neutrophilia then. For the myeloproliferative disorders, we'll cover that in the classes. So if there's an increase in the lymphocyte count, we refer to that as a lymphocytosis. And as I mentioned before, the cell affected really is just in tandem with its primary function. So you will see and can see, and often do see, a lymphocytosis in viral infections. For example, your mono or one of the viral hepatitis like A, B, C, D. Pertussis paradoxically causes a lymphocytosis. Chronic infections, thyrotoxicosis, or toxo can actually cause a lymphocytosis. Monocytes, you can get absolute monocytosis. The count rarely goes above 1, but when it does, we call it an absolute monocytosis. Some of the causes are chronic infections, when you're recovering from an acute infection, connective tissue disorders, or malignant diseases, which we will cover next year. Other causes include protozoal infections. You can get some of the rickettsial or bacterial infections, for example, your brucellosis or your syphilis. I think we've already talked about the connective tissue disorders. For eosinophils, we usually refer to a count above 0.5 times 10 to the power 9 per liter as eosinophilia. And this is often seen in either allergic conditions or parasite infestations, reactions to drugs. You can see it in metastatic CA, or as a result of, for example, radiation. Lophilus occurs with your roundworms. You can get a hypereosinophilic syndrome, etc. But the common causes would be your allergic disorders and parasite infestations. Eosinophilia is more rare. So if we get a count above 0.1 times 10 to the power 9 per liter, we would refer to that as a basophilia. This is really commonly seen in some of the heme disorders you're going to see next year. So like your CML, your primary myelofibrosis, and your polycythemia vera. So that covers some of the common causes of your individual cell line leukocytosis. Let's go into leukopenia, where there's a reduction of your white cell count, and that's usually taken as lower than the lower limit of the reference range for age. So again, it may affect one cell line, or usually it could be physiologic or pathological. So the physiologic leukopenia, for example, in Black Africans, we tend to have a lower total white cell count, and it's usually because we have a lower absolute neutrophil count. You might see this in textbooks referred to as benign ethnic neutropenia, though there's some controversy over that because it's a normal process. It shouldn't really be referred to as a disorder. Then you can get hereditary or familial leukopenias, which has also been documented. Please excuse me for 1 minute. I apologize for that. Okay, so what are some of the pathological causes of leukopenia? So you can get a white cell count reduction because either they're not being produced adequately in bone marrow, or they're being destroyed. There's an increased destruction. So causes of reduced production include, as part of a pancytopenia, generally, there's something wrong with your marrow in general, or your hemopoiesis in general. You can have one group affected, like an agranulocytosis. You could have your bone marrow being replaced either by metastatic CA or fibrosis, or it could be hereditary, and we'll discuss this when we talk about the bone marrow failure syndromes. Increased destruction can occur, for example, with drug use. Steroids are lympholytic, which is why we use them so often in situations where we need to control the lymphocyte counter function, for example, in lymphomas or in, I guess, some of the allergic responses. They also cause a reduction in the eosinophil count. If you have hypersplenism, if you have some infections can also result in increased destruction, for example, viral infections, protozoal infections, or something like, salmonellosis or typhoid. Okay. All right. So I didn't go into the individual cell line leukopenias, but I will mention that we often look solely at the neutrophil count and then maybe the lymphocyte count. For example, patients who are who have HIV and seroreactive, we do look at the lymphocyte count, and you can have an absolute lymphopenia, and then they go further and do, for example, your CD4 count. Yeah. Often we use the neutrophil count as an indicator of your leukopenia. So you can have a balanced leukopenia where everything is reduced, or it could just be one cell line. Okay, let's go into the leukomoid reaction. So sometimes you can have a really high white cell count that mimics like a leukemic condition, yeah, or white cell cancer, but it's not. Yeah, it's just a mimicker. So, for example, in acute infections, if there's intoxication or toxic insult or other malignancies, so the white cells themselves are not clonal, they're not cancerous, but you do have a very high count. This also may be associated with the left shift, whereby you see an increased number of immature forms in circulation. There are various types of this type of reaction. You can have a granulocytic or neutrophilic leukomoid reaction, where that increased white cell count is made up of neutrophils. Or it could be lymphocytic, where that increased white cell count is made up of lymphocytes. There are some changes that are associated with, for example, neutrophilic leukomoid reaction. You will have changes that may be indicative of the positive process. For example, you would see toxic granulation, vacuolation in cytoplasm or dull bodies in a severe bacterial infection that causes a very high white cell count. There's the leukocyte or neutrophil alkaline phosphatase score, which we don't use as much, but it will be discussed as you come and do your lecture with us. So the main issue for the leukomoid is that you need to differentiate it to make sure that it is truly reactive and not clonal, that it's not a leukemia, but really a reactive process to whatever else is going on in the body. We can also have a leukoerythroblastic reaction, where we have a left shift in the granulocyte series associated with the appearance of nucleated red cells in peripheral blood. So if you remember, the red cells from like hematopoiesis extrude their nucleus and their organelles just before they go into circulation. So they usually don't have a nucleus generally in circulation. So the appearance of nucleated red cell is an abnormality. And then the left shift, remember we usually just see segmented forms and at most band forms, if you remember your hematopoiesis lectures. But if we see an increase in the number of band forms or earlier precursors, we will consider that a left shift. This is often associated with drop in cell counts, for example, an anemia, and can be caused by, so I'm seeing the chat flashing. Yes, neutrophil alkaline phosphatase, yeah, or leukocyte alkaline phosphatase, yeah. So it's a stain where you will stain and score the strength of staining of about 100 cells. And in certain conditions, it's increased, for example, in a leukomoid reaction, and in cases where it's clonal or there's malignancy going on, for example, CML, chronic myeloid leukemia, it will be decreased. So you stain them based on, like they're given a score of like 1 to 4, and depending on the strength of staining, you give them that score, and then you do the total of the score for for the 100 cells that you see. We don't do it routinely anymore, but someone might mention it. So it's an example of the cytochemistry that Professor Givanga had mentioned. So back to the leukoerythroblastic reaction, this can be caused by, an invasion of the marrow by a tumor or an infection. So these immature red and white cells are kicked out, so you get a leukoerythroblastic picture in your peripheral blood. Severe hemolysis, multiple myeloma, which we're going to talk about next year, or fibrosis of the marrow. Okay, so let's briefly go into your qualitative disorders. And these are variations in either the white cell morphology and or function. Okay. So some of these morphological changes include, for example, variation in the segmentation of the nucleus. An example of this is Pelger-Huey-forms, where they have a bilobed nucleus. Instead of the 3 to 5 segmentation of neutrophils, I have some pictures which I'll show you shortly. Or in Shirya-Higashi, where you have giant leukocyte granules. We're going to talk about CGD in immunology, and I'm sure you'll see quite a few pictures and look at the effective killing of intracellular bacteria for that condition. And for May-Hegling, we'll see dull bodies, which I'm going to show you right now, but there are 2 to 5 intracytoplasmic inclusions that look like just a really fat granule. So this is an example of cytoplasmic vacuolation. Sorry about the resolution. So you can see vacuoles in the cytoplasm. Yeah. So these are neutrophils, but there's a left shift. I can see the stab. This one is segmented. This is the stab. And you can see the cytoplasmic vacuolation. Okay. Often occurs with severe bacterial infections, bacterial sepsis. This is an example of toxic granulation. Again, these are neutrophils, and you can see in comparison to this, this does have some vacuoles. You can see, these rougher granules. Yeah. So this is toxic granulation, and also occurs in bacterial sepsis. Dull bodies, as I said, this is a 2 to 5 micron intracytoplasmic inclusion. You can see this in May-Hegling abnormalities. We can also see it in severe bacterial infections as well. So some of these morphological changes give us an indication of what's going on in the body and what the underlying pathology is. So this is the Pelger-Huey anomaly. As I said, usually you have for your neutrophils, you have 3 to 5 nuclear segments. And in this case, you've got this bilobed nucleus. Right? And I think we talked about it during the practical, like these nuclear segments are separated by this chromatin strand. Yeah, so if I say bifocals, I think that's like too old a cultural reference for you. But if you just think about bilobed with sunglasses, it might help. Okay, for Shirya-Higashi, really, really dense, of course, granules, which are abnormal lysosomes. And I think we might talk about it during immunology, or if you read up on it a bit more. But basically, there's an issue with intracellular protein transport, and we get these really dense granules that are actually lysosomes. So those are morphological abnormalities as part of your qualitative benign leukocyte disorders. You can also have functional abnormalities where the cell count is normal, they look normal, but they don't function as well. And these are often associated with immunodeficiency states. A lot of the morphological changes that we just discussed are reactive as a result of an insult, such as an infection. But for the functional, because the white cell doesn't work as well, then you generally have a state of immunodeficiency. Examples include congenital hypogammaglobulinemia, and if you remember, your B cells producing immunoglobulins, or George syndrome, which you're going to go into in immunology and in AP. Chronic mucocutaneous, sorry about that typo, candidiasis, which actually happens because of T cell dysfunction, or you can have an acquired hypogammaglobulinemia, which can occur, post chemo, with age, or due to other disorders. But the end result is that the cell doesn't perform its function as well as it should. Okay. So this is an example of an atypical lymphocyte that's seen in infectious mononucleosis. So the thing is, it is functionally okay, but it does look atypical compared to the small, round, mature lymphocyte that I think was on the last slide that Prophet showed you. It has a really nice small nucleus and, scanty cytoplasm. In this case, we have abundant cytoplasm, cells larger, and when you see it, and I'm sure we'll show you, we'll do some slides on it, it often looks like it's hugging the red cells nearby. So you can see the agranular, there's no granules in the cytoplasm, and it's not quite the ground glass of monocytes. I might be asking you to take a leap of faith to believe me, but trust me, this is a lymphocyte and it's an atypical one. Okay? So we see these in, for example, your EBV infection, infectious mono, or for example, in your viral hepatitis, for example, your Hep B, A, etc. So it's responding to the infection. And I think that's it. So in summary, what we looked at today is an overview of your benign white cell disorders. And what you need to remember is that they're divided into quantitative defects or abnormalities and qualitative. And the quantitative generally refers to a numeric function. So there's either an increase, cytosis or aphelia, or a decrease, which is apelia. And the increase is usually as a response to the main cell function. For example, you'll get neutrophilia in bacterial infections, you'll get cytosis in viral infections. For the decrease, you can look at it as decreased production or increase of destruction. And we talked about some of the causes of that. For the morphological, or the qualitative, we talked about changes in morphology. We looked at some of the toxic granulation, the cytoplasmic vacuolation, that occurs as a response, for example, to bacterial infection. So you get the changes in morphology as a result of an insult. Or functional, where the cell count may be okay, the morphology may look normal, but the white cell doesn't function as well as it should. And we talked about some of the congenital hypogammaglobulinemias, or DiGeorge, which you're going to go into. Okay, let me stop there and ask if there are any questions. If you guys are still there.
No, we're still here. Maybe.
Okay, thanks. Does anyone have any question? Either in the chat or if you want to unmute.
Thanks, Dr. Wagutu.
Thank you. Do you have a question?
No, I don't.
Oh, okay. Oh, great. Okay, thank you. Thank you.
Thank you too.
Okay, thank you. Rather than start a trend, thanks for attending class. Does anyone have a question before I log off and let you guys enjoy the rest of the afternoon? Okay, I guess not. All right, thank you. Please have a good afternoon. Stay safe.
You too.